Hey guys, my name is Mallory. I'm one of the neurology technicians here at Mississippi State. I graduated from the technology program here in May of 2021, and that's when I began my job. A typical day for me at the specialty center would be we receive new appointments and we do recheck appointments over there. So if our patient is already slated to get an MRI for that day, we do intake on that patient, get a history, then we anesthetize them, which is my responsibility, and then we put them into the MRI, and I help monitor the patient with the vet student on the case. I draw up drugs, I do catheters, I receive any samples, so urine or blood that we might need on the patient for our test, anything like that. For the rechecks, I will help the resident or vet student or whoever's doing their neurologic exam. I will help restrain the patient for them. I will do 2 o'clock treatments on our patients in wards. I'll pick up prescriptions. I'll help out in ICU. If we need to get any recheck samples on a patient that's in hospital, I'll do that. If we need to do any x-rays or CTs or anything like that, that's also my job. I put in sedation. I help the resident or student on the case with that as well. I work with our radiology department to get that done and accomplished. I help with anesthesia requests. Then I help with discharging patients, supervising and running visits, alerting our front desk staff over at BSC if we have any patients to go home. I help with the billing, that sort of thing. So we begin with our patients for the MRI by sedating them. Our typical protocol is dexmedetomidine and butorphanol. We also give Cerenia or meropitant to help with nausea after anesthesia. And our induction agent is almost always propofol unless our patient has a heart issue. We typically sedate them back at induction, but because our patient today is so large, we sedated them in our exam room and then we transported them back to induction. Once we get them hooked up to our monitors and all, we make sure that our pressures are good, that our heart rate's steady, that it's not too low. If it is, we'll reverse our dexmed. And we give atropine if our heart rate is too low as well. After we get our levels good and steady, we will begin our actual induction process. This is when we push the propofol or whichever induction agent we're going to be using. We always make sure we have somebody with a hand on the pulse so we can make sure that our heart rate does not bottom out or crash when we do begin giving the induction agent. So we a lot of times will intubate our patients in sternal, but sometimes we will in lateral as we're doing today. Lateral is a little bit more challenging, but luckily his trachea is large enough. It's not as much of an issue today. So once we get him intubated, I like to always have our end tidal hooked up to our anesthesia machine, and then we'll get him hooked up and we will leak check to make sure that our system is nice and tight, and we will then switch them over to the ventilator. Now, since we're running an MRI on our patient, we have to have them completely still for the scans, and that's why we most often put them on a ventilator. It allows us to have more control over their breathing and better monitoring. Switch them over to the vent. We'll also turn on our ISO, and we try not to go above 2 if it's not necessary. We'll run him on about 1. He's a bit of a lightweight, so we're just gonna run him on 1. So once we switch to the vent, we make sure our end tidal gets in the proper range, 35 to 45. A little tidbit for you, he is a spine dog, but on our brain dogs, we often run them a little lower, about 25 to 35. This decreases the intracranial pressure because your carbon dioxide will increase it. So our neurologists prefer us to run it a little lower. So once we get everything settled, once we get our end tidal lower, once we get it in the proper ranges, make sure our heart rate's good, pressures are good, we will discuss with our radiology team in the back and be sure that we're good to go. So we first go to the CT scanner to do a metal scan. Now this is only for our outpatients. Sometimes we can have them done in our radiology department over here at the vet school with just an x-ray. We just have to make sure there's no metal in their bodies for the MRI, because if, for example, there was a bullet close to their heart, you don't want the magnet to allow the bullet to travel. That can cause a lot of problems. So we like to make sure, if they have bullets or microchips or anything like that, they're also not in an area that's going to affect our scan and affect the quality. So this is what we're doing right now. We're just gonna stop in CT, and we don't have to position them for this. We're just getting a simple scan just to double check for the metal. So it's a very quick process. After that, we'll begin our transport to the magnet. So once we get to the MRI, none of our students are allowed to go in due to safety protocols. So the radiology staff here at Premier, as well as myself and Ashley, one of our other technicians, and our resident, Dr. Mooney, we're gonna get him situated on the table. We do have monitoring equipment for them in the MRI. We have end-tidal and blood pressure. Due to our monitoring equipment, we cannot have an ECG lead in there because of the magnet. So those are the most important ones to us, though, are the end-tidal and your blood pressure. Our end-tidal can alert us if our patient is waking up, or a lot of times with bigger dogs, they'll begin bucking the vent as they are panting because they get too hot in the magnet. So if that's the case, we bag them down with ISO. So we have to make sure our patient's secure. We also have to make sure they're straight as possible. So that's why you'll see all of these foam, we call them tacos, that we have them in, as well as all of the straps that we use to keep them nice and still and positioned perfectly so we'll get adequate scans. We are also going to run a line of IV fluids. We actually cooled these fluids specifically to keep them cooler in the magnet. So that's why we're going to be running these today. We will position our machine and adjust it. Our ventilator is already set from when we set it in induction. So we'll just turn it on and the settings will already be where we need them to be. And then we'll cut our ISO on to about 1. And we run all of our oxygen levels at 2 liters. So from there, we just slide them in the magnet, and then we sit in the back in the control room with our student, our radiology technicians, and our residents, and we make sure that the patient is good and stable throughout the scans. This one today is going to be an hour and a half. Our scans are typically an hour long, but because he is such a large dog, we could possibly have to turn him so we can get the upper part of his spine as well. We put him in butt first because we're going to do thoracolumbar spine. So we're going to scan that, and if we don't see a lesion there, we're going to pull him out, turn him, and put him back in head first. So that's just a little bit of how we do our MRIs. Very speedy process on some days if our patients don't give us any anesthesia complications, because as we all know, with anesthesia there do come risks. So that's a very important protocol that we have to explain to our clients, that with all general anesthesia there are risks.
I'm Dr. Andy Shores, and I'm Chief of Neurosurgery and Neurology at Mississippi State University College of Veterinary Medicine. And I'm here today to talk a little bit about veterinary technicians. My background is that I graduated from Auburn University in 1977. I completed a small animal surgery rotation at Purdue University, and then followed that with a neurology neurosurgery residency at Auburn University. I've been in academics for well over 35 years and have gone through a lot of changes in the profession. Number one, I think we ought to recognize the fact that veterinary technicians really should be referred to as nurses. That is, I think, an important distinction that they need and deserve, and many other countries do have a distinction. Veterinary technicians are an integral part, especially of specialty practices.
So when I was in the technology program, our 4th year, we do rotations throughout the CVM, and for our small animal elective, you get to pick a specialty department that you normally don't get to go in, and I picked neurology. And I really loved, like I said, the patient care that we provided. I loved getting them in the MRIs. The team neuro were also very helpful to me in preparing me to be a technician. They let me be very hands-on. They taught me. They genuinely cared about my education, and that really attracted me to the department itself. As far as the work goes, like I said, I do enjoy running the MRIs, and I do enjoy the patient care involved with the neurologic patients. My favorite thing would probably have to be the patient care, because I've worked on a lot of general practices, so seeing your more critical patients and learning really what they need from you and how to help with pain management and how to help them recover better post-op from many of their surgeries. That's really interesting to me, and that's probably my favorite part, is learning how all of that works together and working with our neurology neurosurgery department and how to form a plan and execute it in the best way for our patients.
Our technicians are invaluable. They're our backbone. They are what we depend on in order to get our work done on a day-to-day basis.